All right. Good morning and welcome to the Osher Center for Integrative Medicine Grand Rounds. My name is Peter Wayne and I serve as the director for the Osher Center. Today we're privileged to have Dr. Ting Bao present on complementary and integrative therapies for cancer-related peripheral neuropathy. But before introducing Dr. Bao, I'd like to share a few general announcements. I'm going to share one of my slides here. So first, I want to remind everyone about our upcoming inaugural conference on the science of Tai Chi and Qigong as whole person health, which is going to take place here in Boston on September 18th and 19th at the new state-of-the-art facility at the Mass General Brigham Assembly Row Complex. You can learn more about the remarkable panel of speakers that we have, the symposium, the particular breakout sessions, and how to register for this conference via these two links. But you can always just go to oshercenter.org for any information. Second, a few practical matters related to today's lecture. If you wish to request CMEs, be on the lookout for a note in the chat feature of Zoom that will give you detailed instructions. And secondly, as you listen to Dr. Bao's lecture today, we encourage you to write some questions for her using the Q&A feature. I'll be collating these and then present them to you in the discussion following the lecture. So now it's my distinct pleasure to introduce our distinguished speaker for today, Dr. Ting Bao. Excitingly, Dr. Bao is the new director of the Zakim Center for Integrative Therapies and Healthy Living at the Dana-Farber Cancer Institute. Prior to this appointment, she was a joint faculty member at Memorial Sloan Kettering Cancer Center, Integrative Medicine and Breast Medicine Services, and also the director of the Integrative Breast Oncology Program at MSK. She's a board-certified breast medical oncologist and medical acupuncturist and integrative medicine physician. She's also the past president of the Society for Integrative Oncology. Born and raised in Beijing, China, Dr. Bao received her medical education at Johns Hopkins School of Medicine with a residency at Johns Hopkins Bayview Medical Center and a medical oncology fellowship at the Kimmel Comprehensive Cancer Center. She also obtained a Master's of Science in Clinical Research from the University of Maryland. Dr. Bao has conducted a number of clinical trials that examine the safety, effectiveness, and underlying mechanisms of acupuncture, yoga, and other therapies to improve cancer patients' quality of life and to address treatment and disease-related symptoms. A number of these studies have been funded by NIH. These will be the topic of her presentation today, entitled Complementary and Integrative Health for Cancer-Related Peripheral Neuropathy. So without any further ado, please join me in virtually welcoming Dr. Ting Bao.
Great. Thank you so much. Thank you so much, Peter, for inviting me. And today is very special to me because it's my first day start working at Dana-Farber. So it's such a wonderful welcome to start with a grand round. So here's my slides. So let's talk about integrated medicine for chemotherapy-induced peripheral neuropathy. Email is the best way to reach me, and this is my brand new email address. So this is my disclosure. And then, like Peter mentioned, this is my background. So I'm a board-certified medical oncologist focusing on treating breast cancer patients. And I'm also an integrated medicine physician. So I've been trained and treated patients, giving them integrated medicine consultation at Memorial Sloan Kettering Cancer Center over the past 9 years. And then in residency, I got trained to do acupuncture. So I'm actually also a practicing medical acupuncturist. And lastly, I'm a physician scientist conducting integrative oncology clinical research. I have so far finished 6 pilot studies, and right now I have 2 ongoing R01 equivalent grant-funded large randomized control trials, which I'll talk about later. So my career goal is really to integrate complementary medicine into oncology practice to improve patients' quality of life and overall survival. So over the past 12 years, my research has really focused on chemotherapy-induced peripheral neuropathy, CIPN. It's one of the most common persistent treatment-related complications and occurs with frequently used chemo agents such as platinum, taxanes, bortezomib. And the common symptoms include pain, tingling, numbness, sensory loss, poor dexterity, and gait disturbance. So what's the mechanism of CIPN? There has been lots of research on this and different theory on this as well. So usually now a few common potential mechanisms. One is the mitochondrial dysfunction, chemo causes, and chemo also can cause oxidative stress and cause nerve damage. And chemo can also cause increased inflammatory markers and cause nerve damage. And also there's some theory about chemo reduce the nerve growth factors, such as brain-derived neurotrophic factor, therefore cause neuropathy symptoms. Okay, so the current standard of care for CIPN, so there are two settings. One is during chemo when patient develop neuropathy. There's no good treatment for that. Usually the standard treatment is basically dose reduction or discontinuation. The problem with that is that unfortunately, there's some studies suggest that the less chemo you give sometimes is correlate with worse overall outcome and increased risk of recurrence. And then also for persistent CIPN after chemo has completed, right now the treatment really focuses on symptom management with different kind of medication, such as narcotics, antidepressants, and anti-epileptics. And the problem with those is they have limited effects and potential significant side effects. And patients just finish chemo or have been on lots of medications. Some of them really don't want to take more medications. So lots of potential for additional treatment. As a result, American Society of Clinical Oncology, their guideline recommend basically no agents are recommended for the prevention of CIPN. This is really not from lack of research. They're having almost 100 clinical trials on this area, and the result is just not promising to the point that we can recommend anything. And so they're just basically recommending if they develop CIPN, we may need to stop chemo or postpone chemo at this point. And then for the treatment setting, after they finished chemo, then duloxetine is actually the only agent that has some evidence to support its use for patients with established painful CIPN. But the benefit is limited, which I'll mention later. Therefore, additional treatment that definitely needed. So how about integrated medicine approaches, such as acupuncture, yoga, and other approach? So let's talk about them. So what is acupuncture? Acupuncture is a traditional Chinese medicine technique of inserting and manipulating hairs and needles into acupoints to achieve therapeutic effect. So what are those acupoints? So those study has shown those are the points are usually with high density of neurovascular structures, low electrical resistance, and is generally between or at the edge of muscle groups. So a typical session involves putting patients on a comfortable bed or massage table, and then acupuncturist inserts the needle and stimulate it. Often we try to reach this de qi sensation, meaning feeling of heaviness, numbness, and tightness. Then we leave the needle in place for 20 to 30 minutes. Sometimes we add electric stimulation. Acute situation, say you sleep wrongly and you have neck pain, 1 to 2 sessions will take care of it. But for chronic conditions, usually require several sessions. I would say at least 4 to 6 sessions before you know if it works or not. So $1 million question or even $1 billion question, how does it work? So there's have been lots of studies on this area, and a number of potential mechanisms have come out. One is neurohormonal pathway. The idea is you insert the needle and stimulate the nerve, and then that sends signal to the brain. It activates this hypothalamus pituitary gland and result in change in neurohormonal peptides such as beta endorphin, enkephalin. Those are endogenous opiates neuropeptides. So that's basically decreased pain. And then other theories suggest maybe it helps manipulate the neurotransmitters, such as brain-derived neurotrophic factor. There's also neural gate theory, basically saying acupuncture causes non-painful stimulation. Remember the dull, achy, not the sharp pain type of stimulation. And then that actually block the pain perception. And some animal studies suggest that acupuncture may work by stimulate the endogenous pain inhibitory pathway and therefore cause analgesic effect. And animal and human studies suggest acupuncture decrease inflammation by decrease the pro-inflammatory cytokine and increase the anti-inflammatory cytokines. And then functional MRI studies suggest it works by modulate brain activities. So lots of theories and lots of actually pretty solid data. And then our field got a boost by this article published at Nature in 2021, 2 years ago. So basically it's a number of really well-conducted research. I'm pretty sure it's conducted at Harvard, animal study. And try to kind of establish a neuroanatomic basis for new electroacupuncture, and suggests it works by drive the vagal adrenal axis. So it goes sort of like this, like 6 well-conducted animal studies, and then basically suggested that we do acupuncture, say at stomach 36.2 point is right around here. And then that basically stimulate this neurons, and then that sends signal here, and then ultimately basically cause decreased inflammation by decreasing TNF-alpha, IL-6. So if you have time, if you haven't read this article, I highly recommend this one. Really well done. So that gives our field a boost because it's very solid, kind of the mechanism, prove the mechanism. And another article is actually also done in Boston area. The lead author is Dr. Vitali Napdo. So this is basically rewiring the primary somatosensory cortex in carpal tunnel syndrome with acupuncture. It's very interesting because very few acupuncture studies really distinguish separate the distal acupuncture versus local acupuncture, whereas this study did. So patients with carpal tunnel syndrome, they have sort of the local acupuncture point versus the distal, which is actually on the feet. And then, so this basically has 3 arms: distal acupuncture, local acupuncture, and sham acupuncture. And then they combine the local and distal and then call it the Brigham acupuncture. Interesting enough is basically at the end of acupuncture, almost everyone has reduction of symptoms. But then the key is at 3 months follow-up, as you can see, the sham acupuncture group, the symptom kind of bounce back, not necessarily back to the baseline, but bounce back more. And then whereas the sort of Brigham acupuncture continue decreasing. So that's fascinating, mainly because if you design clinical trial, if you only focus on this area, you conclude that there's no difference, right? In patient-reported outcome, whereas if you follow up longer, there is difference. So may need to follow up after they stop acupuncture. But also very interesting is that there's a number of objective endpoints in this study. Fascinating. One is the median nerve conduction latency. So as you can see, the real acupuncture actually really improved. compared to the sham acupuncture. And then they also did MRI study and basically find out the cortical separation also improved in the real acupuncture group when compared with sham acupuncture group. So the proposed mechanism is acupuncture caused the symptom improvement, and then in addition, it's actually caused the nerve improve, and also there's change of neuroplasticity, and ultimately causes long-term symptom improvement, not just short-term. So lots of mechanism, lots of great research, and then so it really make acupuncture sort of very sort of more and more people really believe there's some merit in the mechanism, and yeah, a very valid approach with lots of evidence. And then in addition, we also, multiple people have done amazing research, basically showed acupuncture is safe when performed by qualified practitioners. Look at the risk profile. So basically for the severe adverse event, the most severe would be pneumothorax. When the needle quality wasn't as good many years ago, there's broken needles. And this like rarely happened, never happened now. And then infection. So, but the rate is really low, as you can see, 0.05 in 10,000 treatment. And then also there's like minor sort of common side effects, such as bleeding and bruising. This happens more often, but I always often tell patients the size of the acupuncture needle is actually smaller than the needle they put in to draw blood. It can tunnel through the needle they put into draw blood. So as a result, the bleeding and bruising is pretty minor and just resolved. So go back to CIPN, acupuncture for CIPN. So basically, this is the Alliance study. It's a big cooperative group conducted this wonderful randomized control trial comparing people with moderate CIPN, give them duloxetine versus placebo, and for 5 weeks. And then as you can see, the duloxetine group reduced the pain by about 1.07 on a 0 to 10 point scale, whereas the placebo reduced the pain by about 0.3. So the difference is about 0.7. And yeah. So, and then they have toxicity such as fatigue, insomnia, and nausea. And around the same time, our group, at that time, I was at University of Maryland, we showed that it's a single arm trial. Basically, patients with moderate CIPN with caused by Velcade, also called pertuzumab, and their average pain reading is about 42 out of 0 to 100 point scale. And then after 10 weeks of acupuncture, the pain reduced to about 20 on the same scale. And importantly, after we stopped acupuncture, the pain reduction continued. And the side effect is mild bruising. So it's pretty encouraging. So it's definitely worthwhile continuing. So then I moved to Memorial Sloan Kettering Cancer Center and then got a pilot grant to be able to conduct this follow-up phase 2B trial. Basically, we have 75 patients. We randomize with moderate to severe chemo-induced peripheral neuropathy. And then we randomize them to real acupuncture, sham acupuncture, and usual care, and for 8 weeks. So as you can see, the pain reduction already started at week 4 and continued at week 8. And importantly, at follow-up persisted at week 12. And sham acupuncture reduced a little bit, not minor, so about 1 point, and then but at follow-up it kind of bounced back, and usual care didn't really change much. So inspired by this promising pilot data, we got an NIH R01 grant, which later converted to R37, which is a merit award. And then, so that's basically it's a 5 years grant and supporting us to conduct a randomized control trial. And with the target enrollment number is 250. So my co-PI is Dr. Jun Mao, my mentor, and Iris Zhi, my mentee at MSK. And this is a single center when we got the grant at MSK with 7 sites in like New York, New Jersey area. So this is a study design. So our primary aim is really to determine the efficacy of the 8-week electroacupuncture with sham acupuncture to reduce CIPN symptoms, especially pain. So as you can see, the study schema, we actually got rid of the usual care arm, meaning because the pilot study shows both, especially the real acupuncture arm is significantly better than usual care. So we don't necessarily think we have to have a usual care arm. And then importantly, we calculate the sample size and really want to see if there's difference between electroacupuncture and sham acupuncture. So randomized to 2 arms, and then follow-up is actually longer. Now we have more funding, we can follow them up longer and see how long really the effect is lasting. So efficacy is primary aim. And also we want to see if there's any change in more objective endpoint, such as the small sensory fiber function measured by quantitative sensory testing. And lastly, we also want to see that if there are any biomarker to predict the response to real acupuncture versus sham acupuncture. I practice acupuncture in clinic. I know of a fact, or like, and also talking to other acupuncturists, not everyone respond to acupuncture. So who respond? Do we have to like give like at least 6 acupuncture treatments to everyone before we know whether they respond or not? Is there any biomarker to show, to predict whether they respond or not? As a result, so we're doing a number of quantitative sensory testing to see if that can help predict response. So stay tuned. So here is where we are. We got the notice award in December 2020, and then we opened the enrollment about 6 months later. And our targeted enrollment is 250 patients. Right now we have 110. We basically enroll 1 to 2 patients per week. And the goal is to complete enrollment by April 2025. So what's next for ACT, acupuncture CIPN treatment trial? Now I'm moving to Dana-Farber Cancer Institute. We want to make it like a multi-center trial. We definitely will open it up at Dana-Farber. The goal is to open it in November, hopefully. And then we also want to further explore the mechanism of CIPN and how acupuncture may work. So with the merit award, we actually, we're going to submit additional AIM-4 application by July next year. And then we may add a number of endpoints, such as looking at the inflammatory markers and also BDNF, and also work with Vitali's group and see if there's change in functional MRI. So stay tuned. So that's acupuncture. That's how I kind of really started on this, my research on integrative medicine. And then, but integrative medicine is more than acupuncture. It's also so many other modalities. How about yoga? So in 2016, our group published a study, basically it's an observational study in patients. We did a questionnaire of breast cancer survivors. And a question is to ask them how's their CIPN, what's their severity of CIPN. And also we want to see their rate of falls. You can see there's like dose response. The worse CIPN is, the higher rate of fall is. So that makes sense because they're having sensory damage, nerve damage. So how about yoga? Yoga is a meditative movement therapy. It helps strengthening the body, increase flexibility and mind-body awareness. And evidence really suggests yoga can help improve anxiety, fatigue, and improve function, and prevent fall. And most cancer centers offer yoga therapy anyway. Can yoga, hatha yoga, help reduce CIPN symptoms and reduce risk of fall. How does it work? We don't know the mechanism as well for yoga as well as for acupuncture, but still more and more studies are coming out. There's some hypothesis it may work by increased blood flow and oxygen supply, therefore have this neuroprotective effect. It may help by decrease inflammation, and it may help decrease anxiety, depression, mainly because I didn't really have time to show this, but our survey study also suggests that the worse patients' anxiety and depression is, the worse their CIPN is. They're kind of correlated. And then may helps increase brain-derived neurotrophic factor. There are a number of yoga studies suggest that. So maybe by that, it helps with CIPN. So around the same time, we're doing a pilot study, the phase 2B study on acupuncture CIPN. We also got a grant and support this pilot study to see if yoga can help reduce CIPN. So this is a single center phase 2B, 2-arm pilot study, 40 patients. And then we really want to see if there's any signal to suggest yoga helps, and then potentially can help design a fully powered randomized control trial. So this is the study schema for the pilot study. 2-arm study randomized to yoga versus weightless control, usual care. And to incentivize patients, at the end, we added 8 weeks yoga session. And then, so they have 1-hour yoga instructor-led class twice per week for 8 weeks. And in between, they do home-based yoga practice, and then followed by home-based yoga practice for 4 weeks. And then weightless control, basically usual care for 12 weeks. So this is the main result. As you can see, to our surprise, it helps with pain as well. So basically the yoga arm decreased pain by 2 points out of 0 to 10 point scale. So that's not trivial. And the usual care group didn't change much. And then importantly, the FACT NTX change, which is a questionnaire, 11 questions assess their CIPN symptoms. Also 3 questions assess their function. If they can like button their buttons, if they can feel the small objects in the shape of the small object in their hands, and if they have trouble walking. So the higher score, the better. As you can see, the yoga group actually did significantly better, especially at follow-up 12 weeks compared to the weightless control. And then another one endpoint is functional reach test. So this is a test we ask patients to close their eyes and reach as far as they can before they feel like they're going to fall. So as you can see, the higher the better. Even starting from week 4, there's a separation. The patient's functional reach test significantly improved, which suggests reduced risk of fall. So all this data are very promising. And adverse event, basically, any kind of exercise, you have some like a muscle pain and leg cramps, and all grade 1 basically just resolved in a few days. And pretty promising. So we use this data to submit another R01, and then we got funded 6 months after we were funded for the acupuncture CIPN trial. So it's a randomized phase 3 clinical trial for yoga for CIPN, YCT trial. So this one, actually, reviewer requested us to, suggested us to add a attention control at least. So this is 3-arm trial. Yoga group, education group, and usual care group, and in 2:1 ratio. And treatment is 8 weeks, then we follow them up for up to week 24. So our aim, similar to ACT, basically determine the efficacy of yoga. And then also we want to see if help with improving balance and reduce fall. And also, improve the quality of life. And then we're doing the quantitative sensory testing as well, although this one we make it optional, mainly because of COVID. I'll explain. We got the award notice in March 2021. We took us a while. We started enrollment in November, and unfortunately, that's the time Omicron hit. So COVID. So we basically, 2 patients in the first 2 months when the yoga was like in person. So finally, it's just not happening. We converted all the yoga session at that time to virtual, and then open nationwide. If you're on Twitter, now it's like X. So we were advertising on Twitter and everything. And then so gradually now the enrollment is start picking up. And we now have 84 patients out of like 268 patients. We're enrolling 1 to 2 patients per week as well. The goal is really to complete the enrollment by December 2025. And that's actually why the QST, quantitative sensory testing, is converted to optional, mainly because if you do virtual, it's really hard to ask patients to come in to do an in-person quantitative sensory testing. So next step, also we're going to start it at Dana-Farber, and then at some point we would like to restart the in-person yoga session. And Dana-Farber just last month started the in-person yoga session. So we're hoping to be able to start 2 classes per week for this. And as well, we would like to explore some mechanism of CIP and more mechanism exploration. So that's the treatment setting, which is most of our research focus on, but there's always sort of the prevention setting. As a breast medical oncologist, it's what truly bothers me is when patients are having symptoms and then all you can say is let's delay the chemo dose or stop the chemo, which may increase your risk of cancer recurrence. It just doesn't sit well. So we are really motivated to find additional treatment for CIPN prevention, prevent the worsening of CIPN during chemo. So this is basically right now is conducted at MSK. I actually know that we don't, since today is May Day 1, I know he's conducting a similar trial at Dana-Farber right now. So we will have 2 phase 2 CIPN prevention during chemo trial ongoing, one at Dana-Farber, one at MSK. It will be amazing for the field. So this trial is basically funded by Gateway Foundation, and the PI is Dr. Iris Zhi. And this is acupuncture for taxane-induced peripheral neuropathy prevention. So this is basically based on our pilot data, which is a phase 2A trial and published in 2018. So this is a single arm trial. This is supported by NIH R21. And it's for patients basically undergoing weekly paclitaxel. Once they start having, as you can see, the neuropathy symptoms are getting worse. And then once we developed a grade 2 CIPN, meaning it started affecting their function, then we intervene, giving them weekly acupuncture treatment, and then until they finish chemo. So this is the main result. So it was getting worse and worse. And then the moment we start acupuncture, the symptoms seem to plateau and continue that follow-up. So based on that promising data, we're now conducting a phase 2 trial. So we're enrolling patients once they develop grade 1 CIPN and randomize them to real acupuncture until the end of chemo versus sham acupuncture. And study is ongoing. We want to see if real is better than sham in preventing the taxane-induced peripheral neuropathy. And also we want to see if it makes any difference in chemo adherence rate. If acupuncture can help prevent the worsening of CIPN, maybe then we can prevent the dose reduction or discontinuation, and therefore increase the relative dose intensity of chemo. And the higher relative dose intensity is correlated with better disease-free survival. So that's the ultimate goal, actually. And right now, so we have two phases, screening phase, we screen them the moment they start weekly paclitaxel, then intervention phase. And we're a quarter in, and we're hoping to finish enrollment in 1.5 years. So that's basically two settings and then two intervention. How about others? So what's the future? So I think the future, I'm really curious how it works. I know, I just think it's really important to understand how it works. Also, it's much, much more convincing when you can really explain to patients how it works. Not only make you feel better, but exactly what's the mechanism, and is there any long-term effect of this, so that you don't, once you start the treatment, then you don't have to be on it weekly forever. So we'll see. And then how about other integrated medicine modalities? How about massage? How about Tai Chi? There's so many research about Tai Chi for balance. So I really can see that we can work together, like see if Tai Chi can help with CIP and prevent fall. And how about exercise? And how about different setting? We talk about after chemo is sort of NED, no evidence of disease setting. We talk about during chemo setting. How about metastatic setting? For patients with metastatic disease, continue getting chemo. So we have some pilot data. So at MSK, our massage therapist basically provided us some feedback saying people with CIPN seem to respond really nicely to massage. So we did a little chart review and focus on 23 patients with CIPN symptoms and received a massage therapy, and it's pretty preliminary. So self-reported CIPN severity score before and after massage therapy. And it seems like pretty promising. The main score reduced from 4.9 out of 0 to 10 point scale pre-massage to 1.8 post-massage. So promising and no side effects so far we found. So definitely worth continuing. My other mentee, Dr. Ming Xiaoyang, has followed me to Dana-Farber. So he will start as instructor. Actually, he's starting today as well. So he's actually working on putting together the protocol on massage CIPN, potentially in metastatic setting. We'll see. And how about exercise? So exercise is good for so many things. And then there's some study basically shows exercise may be helpful for CIPN. So we did a chart review for patients entering the breast center survivorship clinic. And this is more than 5,000 patients. And then we found that the prevalence of CIPN was actually lower among the exercisers compared to the non-exercisers. And there's even a dose response result. And as you can see, the more exercise they do, the less CIPN they have. So promising. And this article right now is under review. And we're hoping to, at some point, work together with the amazing exercise group at Dana-Farber, potentially do exercise CIPN child. So this is my vision, is in my tree. So basically, I was just thinking, this is a major problem, the CIPN tree, and we have different branches. We have different setting, like, as I mentioned, no evidence of disease, prevention during chemo, and metastatic patients. And then with different integrated medicine modalities, and then just branch out and also look at different outcomes. So right now, the yellow highlighted ones are ongoing, and then the green ones are in plan. So this is a major tree coming up. And so with that, I think it's the end of my talk. So I really want to thank all these people. It took so many people, so much support from so many different places to get those research done so far. And we definitely need more support to continue building the tree. And that is CIPN. And ultimately, there may be other trees for hot flashes, for aromatase inhibitor-induced joint muscle pain, for chemo brain, for insomnia, etc. So the sky is the limit. There's no limit. And lastly, I just really want to thank our patients. Without them, none of this can be done. That's it. Thank you.
Dr. Bao, that was fabulous. Thank you. So comprehensive and so exciting. And we really welcome you here to the Boston area. I know you and I have met a bunch, and I see lots of opportunities for synergy and collaborations between you and Dr. Liu and Dr. Ligabel and many others, and Ming as well. So welcome and very exciting.
Thank you.
I want to start with an obvious question, which is each one of these shows promise. Perhaps, although it's not fully understood, via different mechanisms. Certainly doing yoga engages a lot more physiological systems in some ways, movement, breathing, behavioral changes, versus acupuncture, which is a bit more passive and receptive, and maybe different molecular mechanisms. I'm wondering what you think about synergies between these treatments. Many people, for example, who are undergoing chemotherapy or recovering, do multiple things. And our approach to research often is to break down things into pieces. But do you see some opportunities for synergy? And if so, would it be an additive effect or maybe a synergistic effect? And which combinations make most sense? And I'll just add to the end of that, what as a clinician, what's your dream intervention if you didn't have to care about evidencing all the little pieces? But are there supplements? Are there herbs? Are there other combinations besides acupuncture and exercise?
Wow, thank you so much, Peter. That's an amazing question. We've been talking about that as well, mainly because, when I talk to clinicians, they were like, okay, one works, the other works too. Why don't we do it together? And I agree. I think in practice, in reality, we should, like lots of patients want to do that as well. However, each takes time. Just for your information, I'm sure like sometimes patients are like, okay, I'm so busy like doing all this, so maybe can you tell me how to streamline this approach? Then I try one and then see, and then move on. So I have seen patients like kind of doing acupuncture. They finish the trial, then they think it's really helpful, but they just couldn't do it every week anymore. So they ended up doing like once every 2 weeks, and in between they would do like a massage, and then at home they would do like yoga or tai chi. So that's kind of the ideal situation. And honestly, there's some promise on, and to be honest, I think everyone should exercise. So that's almost like a baseline. Everyone should do some kind of exercise. So yeah, first, I would say for mechanism study, we probably need to focus on one modality at a time. But then when we go to reality for like sort of the practical aspect, we may want to combine a couple, maybe not all of them together, but yeah. And that's one actually, the PCORI grant is really focusing on like patient-centered one. So if we were to move on to PCORI, we want to involve the patients in to help us to potentially design a more practical study, right? Maybe have a number of them like combined together. And yeah, so this is ongoing. That's another branch of the tree. So ultimately we see all this works, and then we combine them together and provide the patient the best care. Yeah.
Yeah, I think there's some opportunities, this great value into this more reductionist approach of looking at each and understanding mechanisms. And then there's some great value for the pragmatic or practical approach of putting it together and including patient's choice.
Yes.
But just in terms of synergy, the obvious one is if people are in pain, they don't want to exercise. But if
Right.
we can modulate the pain even a little bit to get them to exercise, and then the exercise further reduces the pain, that's where one can equal more than two. So I think there's some great promise there.
Totally.
Yeah, a couple quick questions that people wanted some clarification for
Mhm.
your acupuncture study at MSK,
Mhm.
which is more post symptoms. When do you start those treatments? Are they still involved in chemotherapy, or have they finished their course of care?
Yeah, great question. So eligibility criteria is basically you have to finish chemo after 3 months. So, and then still have CIPN, mainly because some study shows some, especially for taxane-induced peripheral neuropathy, once you stop chemo, basically the CIPN severity in some patients decrease. So if after 3 months, patients still have moderate to severe CIPN pain, then they're eligible for the trial.
Yeah. So I'm going to follow up on that. So of course you know the work that Weidong Liu and others have been doing more in terms of prophylactic care to try
Yes.
to prevent these symptoms. And so those would start either just prior to treatment or at the very beginning of treatment, in contrast to the design you just described. And I'm curious, based on what you know, whether you think the approach for prevention versus the approach for treatment would be different in terms of your strategy with acupuncture, the types of points you'd use, the types of stimulation.
Wow, you really ask great questions. So it's the reason why we didn't do the way Weidong is doing, which is good, mainly because we want different trials, is because Don Hirschman's group has done a trial actually before all this, and Heather Greenlee. So basically they intervened the moment they start weekly paclitaxel, randomize them to real acupuncture versus sham acupuncture. This has been published. And surprisingly, the sham acupuncture group did better than real acupuncture.
Mm.
And so they and then they were using electroacupuncture. So afterwards, I talked to Dawn Hirschman, and she was like, "Okay, we're not going that route anymore." The reason for that result, one is they were using electroacupuncture. We were wondering if it's too much stimulation compared to manual acupuncture. As a result, in our trial, at least we do manual acupuncture. We don't do electroacupuncture. And then I don't know, we don't design like acupuncture intervention yet, but I'll talk to him about that. And another reason is when we look at the 100 patients we screened during our phase 2A study, 20% patients never developed CIPN. At least they didn't really report CIPN symptoms. So you cannot improve that. And then for those patients, if you add like, I don't know, you may even make them worse, right? If you do acupuncture. So I think it's tricky. The prevention setting is a lot harder than the treatment setting.
Yeah.
So lots of details, but then it's good that now it's going to be 3 studies coming out in this setting. Then we can really compare notes and then try to refine what's the next step. I personally, like in our practice, if not in the trial, I don't necessarily say go do acupuncture for CIPN prevention, which they usually put needles around here, 8风8血 points. I just say, add acupuncture once you develop symptoms. Yeah.
Yeah. Well, I think this also echoes your call for biomarkers, not just for who is a responder to acupuncture, but at baseline, which cancer patients are more likely to develop peripheral neuropathy, and then those would be more likely to benefit from the preventive treatments. So
Exactly.
I
Yeah.
think this mechanistic work is really important. And I do believe that Weidong's study is just published now or about to be published, but they saw some positive effects. It's an international multi-site trial with Dr. Ligabel as well.
Yeah.
Yeah.
Yeah, I'm not sure if you're referring to the hot flashes, but let me talk to Weidong. Yes.
Yeah.
Yeah.
Um, so a couple other practical questions. Why did you choose Hatha Yoga? And can you clarify whether the virtual treatments were synchronous with a teacher or they were practicing virtually on their own? And are the protocols publicly available? Some of the yoga teachers want to know.
Great. Yeah, I'm so glad we have such a diverse group. Thank you. So the Hatha yoga, so basically, lots of patients with CIPN has limitations. So we decided not to do those like rigorous yoga, and that's posed a lot challenge on them. So Hatha yoga in general is more sort of mind-body connection and milder, gentler. And then also because I do yoga myself. I don't pretend I'm a yoga expert. So I heavily rely on our yoga instructor and I work with them. So they basically developed this protocol and then worked it out nicely with our patients. So the protocol itself is not published because it's still on ongoing clinical trial. However, the pilot study has been published, and the yoga, I think we did describe like what kind of yoga we did. So did I miss one part?
No, I think that covers it. Yeah, the home-based, how was it delivered within the home?
Oh, okay.
Was there a teacher teaching synchronously to groups of people? Did they have recordings?
That's a great question. So the home practice, we give them recording. So there's a site they log in, and then they basically just do home base. It's very similar to in class. In class, Zoom class is like real time. Like yoga instructor would watch 3 to 4 like patients, and then make sure they do everything right and safely. And then at home, a similar approach. So the yoga instructor record a video and then have them just basically follow. Yeah.
All right, I'm going to give you another challenging one that I've been thinking about. So you and I have talked about some of the earlier work that Brad Manner and I and others have done on peripheral neuropathy related to diabetes and how Tai Chi shows some promise there. Well, one of the things, and so what we found is that changes in the sensitivity of the feet, which are diminished along with pain, as a result from peripheral neuropathy, can be treated or at least responds to Tai Chi. What we wanted to know is whether those changes are local, in other words, changes in the sensitivity of these nerves and the environment that they're in, or whether that change in sensation had to do with what was going on in the processing centers in the somatosensory cortex and other places. And I know that QST can give you some sense of peripheral versus centralization of pain, but I'm wondering if if that's giving you some insight, and whether other tools like MRI or plantar sensation or those sorts of things might be the next places to explore, especially for balance.
This is exactly what I'm thinking next step. So that's why at the SAR, Society of Acupuncture Research meeting, I met up with Vitali. So we're talking about, and also Steve Hart and Rick Harris. So they're focusing on QST, and then we're talking about working with Vitali, the MGH MRI group. So then we can do all of them together, like QST and the functional MRI. And then we can potentially see if there's like local changes versus like central changes. And that's so we're all thinking along the same line, and please join us. Yeah,
I point you to the work of Brad Manner, who's now at Hebrew Senior Life, but he and some colleagues back in Beijing have developed an MRI paradigm where you can walk in place without disturbing the image of the brain and look at the peripheral changes in sensation in the feet and activity in the feet in real time. So some real functional translations. How would this affect gait, which is where falls happen? That's
perfect.
exciting. Yeah. Well, let me see if there's any other outstanding questions here. Oh yeah, one other practical question. There are a number of studies coming online now. Rick Harris, amongst others, have been looking at self-acupuncture or acupressure for the treatment of various cancer symptoms, as well as other health-related outcomes. Do you see any promise in acupressure specifically for CIPN?
I would never say no. I just think it's a little challenging. Meaning because I know they have good result for like acupressure for fatigue, and that's like stomach 36 points, and that's a major one. So there's a major point. It's just for CIP, and there's so many points. So because the idea is, you put 八斜八风 points, and then it's just hard for me to think you do acupressure, then it would like 20 points, and then it would like 2 minutes for points, and that's just a little bit challenging. So I'm not totally closed door on this, but I think let's maybe at some point figure out what's the key main points, and then we can move on to acupressure. Yeah.
Well, I want to just take a moment here to thank you again for this remarkable presentation, and to wholeheartedly welcome you to Boston and your family. And but also our doors are open, as you know, for exploring collaboration, and we have a really rich network through the Osher Center, and you've obviously interacted with a lot of them already. I would like to just end with a couple of announcements to the audience before one more thank you to Dr. Bao. So please join us next week, as per usual. Next month, the first Tuesday of every month, it'll be September 5th for our next grand rounds. And that's going to be an unusual format in that we're highlighting the work of 3 of our recent Osher Grant pilot awardees. And the presenters are doing some really provocative work. These pilot grants are meant to be a bit edgy and creative. And some of these are works in progress. But Abigail Batchelder from Mass General is going to be talking about some work on nonverbal measurements of negative self-conscious emotion, in particular looking at body language and the construct of shame, and using really beautiful machine learning algorithms and some nice collaborations with Paolo Bonato's group at the Motion Analysis Lab at Spalding. Ryan Mace is going to, from Mass General, also is going to be reporting on some completed work he and Dr. Brosenow and others have done related to My Healthy Brain, a novel mind-body program for promoting brain health through lifestyle change. So there's a lot of interest in our group here in healthy aging and preservation of cognition. So that'll be an important presentation. And then Michael Goldstein is going to be from BI, is going to be reporting some work in collaboration with Jan Ma here at the Osher Center and others, examining the interactive effects of mindfulness and slow-paced breathing on stress physiology. Again, another really important topic in this group is breathing and health. So you can learn more about these events, you can register for them, and you can even make a donation to help support this program and the Osher Center at oshercenter.org. So again, I want to just take a moment to wholeheartedly thank Dr. Bao for such a great presentation, and thank you all for your participation in this grand rounds today.
Thank you so much.